Hello and welcome everyone to our first screencast lecture on the respiratory system. So let's kind of get right into it here, and we'll start like we always do with a little bit of introductory information, giving you background that'll help you understand what we're going to talk about as we move through the system. First of all, we realize that our bodies are made up of cells, and our cells are the building blocks of our body. And we've talked about this several times already. The human body is comprised of your body, my body, some 60 trillion cells. Actually, somewhere in a range between 60 and 100 trillion cells, depending upon our size. And each one of those cells has to have a constant supply of oxygen. If it doesn't have a constant supply of oxygen to support respiration, it'll die, and it'll die within minutes because it will be without energy. So in addition, each of the cells also needs the ability to dispose of a waste product that's produced as a result of cellular respiration called carbon dioxide. So the respiratory system works together then with the cardiovascular system to supply the cells with the oxygen that they need to carry out cellular respiration and produce energy, and to dispose of carbon dioxide, which is a byproduct of that cellular respiration process. So how does the respiratory system do that? Well, before we can get into the physiology of it, let's take a look at the functional anatomy of the respiratory system. What are the structures that compose the respiratory system? Now, the respiratory system is a fairly complex system, and so what we do is we divide the system up into what we call the upper respiratory structures and the lower respiratory structures. Let's take a look at the upper respiratory structures first, and we'll begin at the nose with the nasal cavities. So air is going to enter the body through the nares or the nostrils, and it's going to pass then into the right and left nasal cavities. So the inside of the nose, the nasal cavities. Now the nasal cavities, in addition to the nostrils, the openings, the entryway into the nasal cavities, are also composed of an anterior section that's kind of this flared region of your nose that we see from the outside. And that anterior region is referred to as the vestibule. So you have two vestibules, one on each side. Now, the nasal cavities are separated from one another by an internal wall, and usually whenever we look at organs, internal walls are called septa. So there's a nasal septum that acts as a partition to separate the nasal cavities one from the other. In addition to the nasal septum, then inside the nasal cavities, we're going to find turbinate bones. You might remember the turbinate bones from your study of the skull in the skeletal system. These turbinate bones are also known as the nasal congi, and that's the way it's pronounced, like King Kong, King Kongi, think of it. Okay, there are three of these turbinate bones, and they then subdivide the nasal cavities into three passageways. So if we look over here on our diagram, we can see the opening, the nostril. We can see this anterior flared region, the vestibule, and then the main part of the nasal cavity itself. Now, the nasal cavity is lined with a mucous membrane, so we see that mucous membrane, but underneath the mucous membrane, it covers the nasal congi. So these are the nasal congi, and dividing the nasal cavity into 1, 2, 3 passageways that we've talked about here. These turbinate bones are very important. They're kind of like little hooks inside the nasal cavities. So whenever we inhale, whenever we breathe air in, the hooks of the bones cause the air to swirl. And as it does, it kind of slows it down and allows the membranes to warm the air, to moisten the air, and to, very importantly, to filter dust and dirt out of the air. And we know that dust and dirt is where the germs are located. Okay, moving from the nasal cavities, then we move on to the pharynx. The pharynx is what we also know as the throat, although any good anatomy student is going to use the term pharynx and not throat in referring to the upper respiratory structures. But this is a common passageway now for both food and air. So the pharynx is not only going to be part of the respiratory system, It's also going to be part of the digestive system when we take a look at that. Now, as you can see over here, the pharynx is fairly long, and so we divide the pharynx into three regions based upon the location. The uppermost region or portion is what we refer to as the nasopharynx. It's this kind of reddish area right here that's right behind the nasal cavity. So behind the nasal cavity, we have the nasopharynx. And then we have this middle portion here in kind of light blue, and that's referred to as the oropharynx. And yep, you guessed it, it's because it's behind the oral cavity. And then the lowermost portion is right above the larynx, so it's referred to as the laryngopharynx, and that would be this kind of darker blue section that we see here. So in this diagram, this is a cadaver dissection, sagittal section of the head. And I just wanted to pop this up so you kind of get the sense of what these things are really like in real time, so to say. So down here we would have the nasal or the nostrils, and then here we can see the flared portion. This is the vestibule, and then behind the vestibule we can see the main nasal cavity. We can see that the congi right here, the nasal congi, and that they're covered by a mucous membrane. And we can see the 1, 2, 3 passageways there that we talked about. Over here on this side, on the left side as you're looking at it, the right side of the frame, we can see this region right here would be the pharynx. And this part is right behind the nasal cavity, so it'd be the nasopharynx. And then you have this portion right here, which is behind the mouth. So this would be the oral pharynx, oropharynx. And then right down here at the very tip, we can see the top of the larynx. And so this would be the laryngopharynx down here. By the way, just a couple of other things that you can see on here. Notice these spaces that we see here. This is the sphenoid sinus. Here's an ethmoid air cell. And this right here is the opening from the eustachian tube from the ears. Here we can see the hard palate anteriorly in the mouth, and we can see the soft palate here, and how the soft palate comes down here and ends as the uvula. So some interesting other structures that we see there as well. Okay, next we move to a structure called the epiglottis. The epiglottis is a flap of cartilage that's located at the base of the pharynx. So what we saw in the previous slide, if we just go back to that for a second, right here at the very top, this is actually the top of the epiglottis that we're seeing right here. Okay, so moving back to where we were, that's that flap of cartilage that we just saw. And here in this diagram, here's our flap of cartilage, the epiglottis. And you can see how it kind of sticks up. It looks just kind of like what we saw in that previous slide. Now the epiglottis is important because this flap of cartilage opens to allow air to enter the trachea whenever we inhale. And whenever we exhale, it's going to close to prevent air from entering the trachea. And it's also going to close to prevent food from entering the trachea. Remember, the pharynx is a common pathway for both food and air. But once we get past the pharynx, we want the food to go into the esophagus. We only want air to go into the trachea. So this flap of cartilage right here, the epiglottis, closes over the top of the trachea to prevent food from entering the trachea whenever we swallow. Okay, next up, our next structure we take a look at is the larynx, and actually the epiglottis is part of the larynx. The larynx is commonly referred to as the voice box, but again, you know, anatomy students, we're going to refer to it as the larynx. It's located in the at the upper part of the trachea, so it's perched right on the top of the trachea. It actually consists of 3 cartilages. One of those 3 cartilages we've already talked about, the epiglottis, is located here. Now we're taking a look, kind of a frontal view here. So here's the epiglottis from a frontal view. And below that, then we have the thyroid cartilage, which is in the middle. And the thyroid cartilage kind of looks like a heart shape. So here we can see the thyroid cartilage here. Here's the actual cartilage. And then there is some muscle that's over top of the surface of the cartilage. And then the lowermost portion right down here of the larynx is referred to as the cricoid cartilage. Okay, so continuing on with our discussion of the larynx, we find internally that the larynx contains two pairs of folds in the internal lining of the pharynx. These folds are referred to as the vocal cords. There are two pairs of them. One, the inferior pair, is referred to as the true vocal cords because they are truly involved in the production of sound. And just above them, superior to the true vocal cords, we have the false vocal cords. They're false vocal cords because they're in that area, but they are not really involved in the production of sound. Between the two vocal cords, there is a slit-like passageway that allows air to enter the trachea, and that slit-like passageway is referred to as the glottis. So here are some diagrams. First, here on the left side diagram, these two white bands that we see here are the true vocal cords. And if you were to look at true vocal cords, they actually are kind of whitish like that. And so that's kind of, even though this is an artist's conception, that's a good, that is a good depiction there. And then alongside of those two, probably better seen over here, we can see these second folds that kind of run laterally and superiorly to the two true vocal cords, and these are the false vocal cords. Between the vocal cords, we can see the slit-like passageway, and here we can see the passageway is opened up, and this is the this shows the glottis. Now, here's a slide that I'm not going to go over right now, but you can take a look at it. I have it posted on Canvas. This is Beth's first laryngoscopy. I recommend you look at it. It helps you get a better understanding for the vocal cords and how the actual the vocal cords actually work to produce sound. So there's the picture, and again, you can take a look at that in Canvas under videos and animations. All right, that's going to take us down to the next structure. The next structure we look at is the trachea, but notice on our slide we changed functional anatomy from the upper respiratory structures to the lower respiratory structures now. So the lower respiratory structures actually begin with the trachea. What is the trachea? Well, it's what we also know as the windpipe, but of course we're not going to call it the windpipe, right? We're going to refer to it as the trachea because we're all good anatomy students. The trachea is going to extend inferiorly, as we see in this diagram then, from the larynx approximately 4 to 5 inches. So it depends upon the size of the individual as to exactly how long it's going to be. Notice in the trachea we can see these rings. These are rings of cartilage, hyaline cartilage, that reinforce the walls of the trachea. Now we refer to them as C-shaped rings because in the back of the trachea, they come together and they may even overlap a little bit, but they're not continuous. And so it's kind of like there's a C shape, we say, to them. And that's important. That helps to reinforce the walls and keep the trachea open so it doesn't collapse to allow the air to get in. The trachea itself is going to terminate by dividing into two bronchi. Okay, so we're going to have a left bronchus and a right bronchus, the two bronchi. Let's take a look at those next. So the bronchi are actually going to conduct the air directly into the lungs. As I mentioned, there's a left bronchus or a left primary bronchus that's going to conduct air obviously into the left lung, and there's a right primary bronchus that's going to conduct air into the right lung. You may note here on the diagram that the right primary bronchus tends to be shorter and steeper or more vertical than the left primary bronchus, and it also has a wider opening to it, so it has a greater diameter to the lumen of the bronchus. And we can see over here on the opposite side, you can see how this left primary bronchus is a little bit longer, not quite as steep, and not quite as wide. Structurally, the bronchi, both of them, are similar to the trachea in that we can also see the C-shaped rings of hyaline cartilage that help to keep them open. Now, the bronchi then themselves will divide in the lungs, inside the lungs, into secondary and tertiary bronchi. Eventually, then, those secondary and tertiary bronchi will continue to branch until, just kind of like what we saw with the arteries and veins, until you get to the smallest of the bronchi that are just barely visible to the naked eye, and they're referred to as the bronchioles. Eventually, the bronchioles will become respiratory bronchioles, and the respiratory bronchioles, like this one right here, will lead directly to the alveoli. The bronchioles then will carry the air into and out of the alveoli. What are the alveoli? Well, see these tiny sac-like structures right here? These are the alveoli. They tend to cluster at the end of the respiratory bronchioles into grape-like clusters. These are tiny air sacs, and their importance is this is where oxygen and carbon dioxide exchange between the lungs and the blood is going to occur. Each of the alveoli, as you can see here, is surrounded by a network of capillaries. And that's important because the carbon dioxide and oxygen exchange is going to occur between that alveolus and the capillaries that adhere to the surface of the alveolus. Okay, and then that takes us to the lungs themselves. So if we're kind of going to pull back now, we were looking at the interior of the lungs. We're going to pull back and look at the outer surface of the lungs now. The lungs themselves are located, as you know, in the thoracic cavity, and each of the lungs is divided into lobes. Note that the left lung has 2 lobes here, and that the right lung has 3 lobes. We'll compare that to the cat whenever we take a look at the respiratory system of the cat. Now, this lobe nature of the lungs is important because, let's say, for example, if somebody has a lung disease, because the lungs are partitioned this way, a portion or a lobe of the lung can be removed, and it wouldn't have any substantial effect on one of the other lobes of the lungs. So that's an important aspect, the lobes. Next up, whenever we take a look, let's take kind of a geographic look at the lungs. We talk about the apex. The apex is this cone-shaped tip at the top. It's the uppermost portion of the lungs. Remember, that's opposite the heart. Remember, the apex was inferior in the heart, but it's now superior on each of the lungs. And then at the opposite end, where the lungs are broader, that's referred to as the base of the lung. There's a space between the lungs that allows for the esophagus to pass through, allows for the heart. That space is referred to as the mediastinum. You can actually see here in the mediastinum where we have the outline really of kind of where the heart kind of fits in there yet. So as I said, that contains the heart, the esophagus, and even the bronchi there in the mediastinum. All right, so that's our basic look at the structure of the respiratory system, the anatomical structure of the respiratory system. So now we're ready to talk about some respiratory physiology. How does the respiratory system do what it does? Remember, what does it do? It works with the cardiovascular system to deliver oxygen to the body tissues and to retrieve carbon dioxide from the body tissues. So whenever we take a look at respiration to an anatomist actually consists of 3 distinct activities that occur simultaneously. Now you have to be careful about this because it could be confusing. You know, clinically, whenever we refer to respiration, you generally think of it as one inhalation and one exhalation. Kind of the physical act of getting the air in and out. But to an anatomist, respiration not only includes getting the air in and out, but it also includes two other activities. And again, all these activities are occurring at the same time. So you kind of have to keep that in mind. What are those three distinct activities? Well, the first one is called ventilation, or what we refer to simply as breathing. And this is going to result in the movement of the air between the atmosphere and the lungs. So the air is moving in and out of the lungs during ventilation. The second activity, and we'll have to look at each of these activities individually, is called external respiration. External respiration is known as lung breathing. It involves, I should say, the events that result in the exchange of oxygen and carbon dioxide between the alveoli of the lungs and the capillaries. So the exchange of air between the lungs and the capillaries is referred to as external respiration. And then the final activity is referred to as internal respiration, or sometimes referred to as tissue breathing. This involves the events that result in the exchange of oxygen and carbon dioxide between the blood and the body cells themselves. So exchange between the tissues and the blood is internal respiration. Okay, so let's take a look at each one of these individually and how they occur. First up, ventilation. And again, ventilation is the physical act of breathing in and out. I can't find a better way, a better simple way to explain it to you than to look at this chart. So we're going to look at this chart. We're going to go down through the steps on the chart. And then we'll also take a look. This chart, by the way, I should step back for a minute, shows the events or what's going to happen on inspiration, or the physical act of breathing in. I'll show you a second chart in a couple of slides that shows expiration, or the physical act of breathing out. So how that occurs. Then after I show that to you, we'll look at we'll show you a little demonstration on these events and maybe try to help explain them to you a little bit better so you understand them. So we'll look for that. Okay, so let's go down through inspiration by taking a look at this sequence of events. So the first thing that's going to happen in inspiration is the inspiratory muscles are going to contract. Now the inspiratory muscles are the diaphragm, and when the diaphragm contracts, it's going to descend. So the diaphragm in our body cavity usually is kind of domed up at the bottom of the thoracic cavity. But what we're saying here is whenever we inhale, that's going to flatten out. Okay? In addition, the rib cage is going to rise because between the ribs there are these intercostal muscles. And whenever we inhale, these intercostal muscles are going to contract. They're going to pull on the ribs, and they're going to lift the rib cage up and out. As a result of that, the thoracic cavity volume is going to increase. And as that thoracic cavity volume increases, it's going to pull on the lungs, and I'll show you how that works in just a bit. It's going to pull on the lungs, and it's going to stretch the lungs out. That's going to increase the internal volume of the lungs, of each of the individual alveoli. So what's going to happen is whenever we inhale, it's going to not only move the chest cavity up and out, but as the chest cavity moves up and out, it's going to pull on the lungs. It's going to stretch the lungs, it's going to stretch those alveoli out, and it's going to increase the internal volume of the lungs. The intrapulmonary volume is going to increase. In step number 4 here, as the intrapulmonary pressure or volume increases, the intrapulmonary pressure that's created by the air in the lungs is going to drop. And we're going to say it's going to drop to -1 millimeter of mercury. Remember, pressure is measured in millimeters of mercury. Think about whenever you take blood pressure. So with an increase in intrapulmonary volume, the intrapulmonary pressure that's created from the air inside the lungs is going to drop to -1 millimeter of mercury. In other words, it's going to drop to a point where it is lower than the atmospheric pressure of the outside air surrounding our body. So what's going to happen? In step number 5, air, or the gases in the air, including particularly oxygen, are going to flow into the lungs as they move down their pressure gradient. So the air is going to move from where there is high pressure to where there is low pressure. The pressure just dropped inside the lungs as the lungs were stretched, and so the air is going to move from the outside and it's going to move to the inside of the lungs. And what's going to happen? The air is going to start to fill up the lungs as it moves down its pressure gradient until the intrapulmonary pressure is equal to 0. So as the air comes in, the pressure inside the lungs is going to start to go up with the filling of that air. Whenever the air pressure goes up, we say to 0 or equal now to the pressure of the air on the outside, the flow of the air in is going to stop. And we've come to the end of inspiration. And again, I'll show you this a little bit better in an additional video that we'll add in just a few slides here. Okay, moving on for now, though, this may help you understand this a little bit better. You might recall in chemistry you learn about something called Boyle's Law. Boyle's Law says that the pressure of a gas in a closed container is inversely proportional to the volume of the container. So in other words, the pressure in a container, as the volume of a container decreases, the pressure goes up. As the volume of a container increases, the pressure is going to go down. That's why what we saw happen in the lungs whenever we lifted the thoracic cavity up and out and stretched those lungs, the volume of the lungs increased and the pressure went down. Now this diagram kind of shows you how that works. So here we have a piston in a kind of a closed container, and these little black dots represent air molecules. You see how as we squeeze the piston down, the air molecules get closer and closer together? It gets to a point where you can't pack them any tighter, and as they get closer and closer together, that's what causes the pressure to go up. So look at our graph over here on the side where we have volume versus pressure. And notice that the volume, as it goes down, look at what happens to the pressure. The pressure increases. But notice as we lift the piston up, that allows these molecules of air to spread further and further apart. So as the volume increases now, look at what happens to the pressure. The pressure is going to decrease. Here's our pressure gauge right down here. Now the reason why this temperature is here is because this all happens at standard temperature. So as long as you don't change the temperature, that's what's going to happen. Okay? So hopefully that helps us to understand this as we continue on a little bit better. So let's continue on and take a look now at ventilation at expiration or exhaling. And again, I think the simplest way to explain this is with this chart and the additions I'm going to show you in just a bit. But so now we're going to take a look at expiration, the physical act of breathing out or exhaling. Let's go down through the sequence of steps. So in the first step, the inspiratory muscles are now going to relax. When the diaphragm relaxes, it's going to dome up. And whenever the intercostal muscles relax, they are going to allow the rib cage to descend. It kind of descends passively as it moves back to its original position, and that's due to the recoil of the costal cartilages. So what's going to happen? Well, as the diaphragm domes back up and the rib cage comes in, the thoracic cavity volume is going to what? It's going to get smaller. It's going to decrease. As the volume of the thoracic cavity decreases, The lungs, since they are elastic, elastic means they'll return to their normal resting position. The lungs will recoil, as I said, passively, and the intrapulmonary volume of the lungs, I keep losing my cursor there. I hope that's not bothering you too much. But the intrapulmonary volume of the lungs, that is to say, the internal volume or size of the lungs, is going to decrease. As that happens, think back to what we saw with the Boyle's Law diagram. As the size of the container gets smaller, what happens to the pressure? The pressure is going to go up. So as the lungs return passively back to their original shape, they're getting smaller and smaller and smaller. The pressure is going to go up and up and up, right? As the pressure goes up, what's going to happen? Now the pressure is going to go up above atmospheric pressure, and now the air or the gases are going to flow out of the lungs once again as they flow down their pressure gradient until, as we can see there, the intrapulmonary pressure is back to zero again, back to even with the atmospheric pressure. So as a result of that, what's going to happen? At the end of that, we're going to inhale again and start to cycle over. So we've got one cycle there of inhalation and one cycle of exhaling. Okay, so let's take a more detailed look at how ventilation occurs. So let me make a little diagram here to represent our chest cavity. There we go. And of course, down in the chest cavity, let's show the trachea. And then we have our bronchi. And we'll put in the lungs. One lung there, another lung there. This is going to be a little exaggerated here with the spacing, but you'll see why we're going to do that as we progress along. Now, whenever we take a look at the lungs, these are internal organs, and recall that we said that all internal organs are covered by a membrane. That membrane is a serous membrane. So let's draw the serous membrane that covers the lungs here. And of course, serous membranes are double membranes, so there's two layers to them, and one layer attaches right to the visceral organ, and the other layer attaches to the inner body wall. So we've got to put in our diaphragm yet. So we'll just kind of extend this down a little bit and draw in the diaphragm. The diaphragm is a dome-shaped muscle, so let's kind of show a dome shape there. Okay, and the serous membrane is going to not only go up against the body wall, but it also will cover or adhere to the diaphragm, completely enclosing the lungs. And of course, between these two membranes, there's a serous fluid. And since this is around the lungs, we call this fluid pleural fluid. So this is going to represent the pleural fluid that surrounds the lungs. And that's going to be important as we go along here. And of course, again, this space is exaggerated a little bit just to show the detail of what we're talking about here. So let's start out with inhaling. So what happens whenever we inhale? Well, remember, those intercostal muscles are going to pull on the ribs, and that's going to, we'll show this with a dotted line here, that's going to pull the rib cage up and out, and that's going to increase the volume of the thoracic cavity. Now, in addition to that, remember what happens is this diaphragm right here, when it contracts, when we inhale, it's going to flatten out. So the diaphragm will show that a little flatter here. Okay, and you can see we have an increase in the thoracic volume. Now, when we have that increase in the thoracic volume, so what's going to happen here now is this body wall is going to be pulled out in this direction, and the diaphragm is going to move down like that. Now, one thing I forgot to mention when I was drawing these in, by the way, is that whenever we take a look at this serous membrane, since it's surrounding the lungs, it's referred to as the parietal or the pleural membranes, excuse me. And this portion of the pleural membrane right here that attaches right to the surface, inner surface of the body wall is called the parietal pleura. And this portion that attaches to the surface of the lung is referred to as the visceral pleura, because it attaches to a visceral organ right inside the body. And then we have the pleural fluid in between the two. So now what's going to happen is when this body wall is increased in size, that's going to pull on this parietal pleura, which is attached right to the inner surface of the body wall. And this pleural fluid that we have in here, so here's our pleural fluid. That pleural fluid does two things. First, it helps reduce friction. To make it easier for surfaces to move across one another. And second, and important in our discussion here, is that pleural fluid kind of has adhesive properties. So because it has these adhesive properties, whenever that parietal pleura pulls, because it's being moved with the body wall, it's going to pull on this pleural fluid, which is going to act kind of like a sticky or glue, and it's going to pull then on the visceral pleura. Whenever and that's going to cause the visceral pleura to kind of get stretched, and that's going to pull on the surface of the lungs. And then what's going to happen is, we'll show the dotted lines here, the volume of the lungs then is going to increase as well. So they're going to get bigger. Okay. Now, inside the lungs, let's draw these little dots, and they're going to represent air molecules inside the lungs. Okay, and so when we inhale and this gets stretched out, the lung gets a little bit bigger, it gets stretched out, and that creates more space between these air molecules in here. Now remember Boyle's law. Boyle's law says that an increase in the volume of a container results in a decrease in the pressure. So what's going to happen is, as these lungs stretch out, it's going to increase the volume of the lungs, and these air molecules are going to be able to move further away from one another in each of the lungs. And as they move further away from one another, the pressure, the air pressure inside the lungs is going to go down, and it's going to go down to below atmospheric pressure. So let's say that if just prior to that inhalation, let's say that the atmospheric pressure, I have enough room to put these in here, and the lung pressure were both at 0 atmospheres. Okay, and we have 0 atmospheres out here. So now the pressure inside the lungs is going to drop, and let's say that is whenever this lung stretches out, and the lung is going to the pressure is going to drop by 1 millimeter of mercury. So now it's going to be -1 millimeter of mercury compared to atmospheric. So as a result, we can see that what happens is the air pressure inside the lungs drops and the air pressure outside the lungs, the atmospheric air pressure, remains the same. That creates a pressure gradient, and now the air moves along that pressure gradient and it follows that pressure gradient and moves into the lungs. So the number of air molecules in the lungs starts to go up. How long does it go up? Well, as the air molecules flow in, then there's more air molecules in the same space, so the pressure is going to go up until the pressure is the same as the atmospheric pressure. Once the pressure inside the lungs is the same as atmospheric pressure, the air stops flowing in. The two pressures equal one another. So that's how inhalation occurs. Now, with exhalation, we're going to have the exact opposite occur. So whenever we exhale, what happens? The diaphragm relaxes, it moves up into a dome. The rib cage, the intercostal muscles relax and allow the rib cage to move back in. And that's going to decrease the size of the chest volume back to the original. No longer does the pleural fluid pull on the lungs, and so the lungs now passively recoil to their original shape, shown by the solid line here. And what's going to happen? Now you have all these air molecules in here, and think about the Boyle's Law diagram again. And what's going to happen is they're all going to get squeezed more tightly together. And as they get squeezed more tightly together, the pressure inside the lungs is going to now go higher than the pressure outside the lungs by, let's say, +1 millimeter of mercury. So what's going to happen? Again, the air is going to flow along its pressure gradient from where the high pressure is to where the low pressure is outside the lungs. So now the air is going to flow back out of the lungs. So I hope this diagram helps you to understand a little bit better how ventilation occurs. Okay, next up, let's talk about external respiration. So now we saw how the air, particularly oxygen, gets into the lungs. Once the air gets into the lungs, the next question is, how does the oxygen get from the alveoli in the lungs into the blood? That's called external respiration. So external respiration then is going to involve the events that result in the exchange of oxygen and carbon dioxide between the alveoli and the capillaries. This exchange of gases occurs entirely by diffusion. Think of capillary exchange. That's really what we kind of have going on here. Now, external respiration occurs, though, across what we call the respiratory membrane. This is also known as the air-blood barrier, the barrier between the alveoli and the capillaries. The alveolar and capillary walls and their fused basement membranes make up the respiratory membrane. So if we take a look at our diagram over here, so here's an alveolus on this side, here's a capillary on this side. And here we can see the wall of the alveolus, very thin wall. It's made up of simple squamous epithelium. And then here is the basement membrane of the alveolus. Now over here, the capillary wall, again, it's a very thin wall. It's made up of a single cell layer of simple squamous epithelium. And here we can see the basement membrane. And these two basement membranes kind of stick together. The proteins are sticky, and that allows the capillaries to adhere to the surface of the alveoli, as we saw in our diagram of the alveoli. So the exchange of oxygen and carbon dioxide is going to occur across this respiratory membrane. Whoops, let's go back to that just a minute. Okay, so how it occurs is, we take a nice deep breath, we load up those alveoli with oxygen, and now you have a higher concentration of oxygen here in the alveolar sac. The blood has been circulating around the body, delivering oxygen, so it's going to be depleted of oxygen. It's going to have a lower concentration of oxygen. So the oxygen is going to diffuse across the respiratory membrane into the capillary bed and eventually into the red blood cell. On the other hand, when the red blood cell comes back into the capillary bed from all the body tissues, you think about it, it's going to have been picking up carbon dioxide from those tissues, so it's going to be loaded with carbon dioxide. The air we breathe in is less than 1% carbon dioxide, so it's a very low concentration of carbon dioxide. So what's going to happen is when this red blood cell gets into the capillary bed near the alveolus, the carbon dioxide is going to be in a higher concentration on the capillary bed side than it is on the alveolar side. And so the carbon dioxide is going to flow down its concentration gradient from the capillaries into the alveolus. And we have external respiration. Okay, now we can move on to the next slide. And in the next slide, we take a look at internal respiration. This is going to involve the events that result in the exchange of oxygen and carbon dioxide between the blood of the capillaries and the body cells. So here's our diagram over here that we'll be following along. Again, this exchange is going to occur entirely by diffusion. And as a result, oxygen is going to diffuse out of the blood and into the cells, and carbon dioxide is going to diffuse out of the cells and into the blood and be carried away. Now, you understand why that happens? This blood is coming back from the lungs, and these erythrocytes, these red blood cells, are loaded up with oxygen, O2, so the two spheres represent oxygen. So the blood's going to have a high concentration of oxygen as it passes by the tissues. So what's going to happen is the oxygen is going to move along its concentration gradient, pass out of the capillary bed and into the cells of the tissues. The cells are manufacturing carbon dioxide through cellular respiration, so they're going to have a high concentration of CO2. And so what's going to happen? The CO2 was just dumped off in the lungs, so the blood's going to have a lower concentration of carbon dioxide, so the carbon dioxide is going to flow along its concentration gradient into the capillary. Okay? It's pretty simple. All right, so now we've taken a look at how the air gets in and out of the lungs. We've taken a look at how oxygen and carbon dioxide get exchanged between the blood and the lungs and between the blood and the tissues. The next question, though, is how do the gases get between those 2 points? Okay, how are the gases transported from, let's say, carbon dioxide from the tissues up to the lungs? How are they actually transported? We know via the cardiovascular system, but how does the cardiovascular system transport them? And we know how the oxygen got onto the blood in the first place, but how is it carried by the blood out to the tissues of the body? That's what we're going to take a look at now, the transported gases in the blood. So we have our two gases, oxygen and carbon dioxide, we're going to take a look at. Let's take a look at oxygen first and see how it's transported. Most of the oxygen that diffuses from the alveoli into the blood is going to bind with hemoglobin molecules inside the erythrocytes, and that's going to form oxyhemoglobin. So what we're saying is most of the oxygen that's transported is going to be transported in the form of this oxyhemoglobin on the red blood cells. Now, some oxygen is transported in the plasma, but it's only a very, very small amount. If you get too much oxygen being transported in the plasma, it'll cause gas bubbles to form, and that could block the flow of blood through the tiny capillaries of the body. So we don't want that to happen. There's a very tiny amount of oxygen that's carried in the plasma, but most of it is carried on the hemoglobin molecules. So when the blood reaches the tissues then that have a lower concentration of oxygen, hemoglobin will naturally start to release the oxygen. And the oxygen will pass into the tissues will use it for cellular respiration. The lower tissues are in oxygen, however, the more oxygen hemoglobin releases. And so when you think about it, what that would do is create a steeper oxygen hemoglobin dissociation curve, or not a curve, but a steeper slope. So the steeper the slope, remember, the faster the rate of diffusion is going to occur, if you recall that from AMP1. So when blood leaves the lungs, it should be about 98% saturated with oxygen. You think about a pulse oximeter, if any of you have ever used a pulse oximeter and you put it on the finger and test what the oxygen saturation is, it should be, you'd like it somewhere to be around 95, 98%, right? However, when the blood returns to the lungs, it's important for us to note that it's not completely depleted of oxygen, that there still is some oxygen that's attached to the hemoglobin on the red blood cells. And we say the hemoglobin is still about 60% saturated, so it's never completely desaturated the oxygen. Now, here's an important concept for us to take a look at. It's called the oxygen hemoglobin dissociation curve. The oxygen hemoglobin dissociation curve shows the relationship between the oxygen that is on the hemoglobin and the level of oxygen that is in the tissues. So as we take a look at this curve, the ability to bind oxygen is actually affected by two additional factors other than the concentration of oxygen, right? Those two other factors are pH and temperature. Now, before we get into that, let's take a look over here at this oxygen hemoglobin dissociation curve. And what this is showing here, along our x-axis, we have the gaseous pressure of oxygen, or tension in millimeters of mercury. Where is that going to be the highest at? In the lungs. So notice that as we're up here, where we have high oxygen saturations, with the blood associated with the alveoli, we have a very high saturation of hemoglobin with oxygen. But as we move to tissues that have lower amounts of oxygen in them, so there's a lower pressure of oxygen because the cells are consuming them, notice what happens, that the hemoglobin saturation starts to drop off. And so we kind of get this kind of S-shaped curve as we take a look at it. So one of the factors we know that determines the rate of oxygen delivery to the tissues is how low the tissues are in oxygen. The lower a tissue is in oxygen, look at what happens. We can tell by the slope of the line here, the faster the hemoglobin is releasing oxygen into those tissues, as indicated by the green line. Now, what we're saying here is the oxygen hemoglobin dissociation curve shows that the ability of the hemoglobin to bind or hold on to the oxygen is affected by two additional factors: the pH of the tissues and the temperature of the tissues. Works out like this. Generally speaking, a decrease in pH or a rise in temperature causes hemoglobin to release more of its oxygen than it normally would. So let's take a look at this with in the case of temperature first. Okay, so notice that a rise in temperature causes an increase in the release of oxygen. So there's a direct relationship there. The warmer a tissue is, the more active it must be. The more active it must be, the more oxygen it must require to remain active. So this fits. The warmer it is, the higher the temperature, the faster the hemoglobin releases the oxygen, and more oxygen is delivered into that warmer tissue. Okay. On the other hand, when we take a look at pH, the oxygen hemoglobin dissociation curve also shows the effect of pH as well on oxygen concentration. So whenever we take a look at it, generally speaking now, a decrease in pH causes hemoglobin to release more oxygen than it normally would. So remember, with temperature, there is a direct relationship between temperature and oxygen release from hemoglobin. The higher the temperature, the greater the oxygen release. But there's an inverse relationship between pH and oxygen release from hemoglobin. The lower the pH is, the faster the oxygen is released from the hemoglobin. So as we take a look at this, what would cause the pH to decrease? Active tissues. Active tissues will release increasing amounts of carbon dioxide. That would cause a lowering of the pH of that tissue. As blood passes through that low pH tissue, that means it's active, it needs more oxygen, so the hemoglobin is going to release more oxygen into that tissue. And hopefully we'll understand that a little bit better, especially this pH, how that works as we move along here and in our second screencast on the respiratory system. But just before we finish up here with the oxygen hemoglobin dissociation curve, so let's take look at these lines. Here, this green line is going to represent, let's say, a pH, normal pH of the blood around 7.4. And so we can see as the blood moves away from the lungs and toward the oxygen-depleted tissues of the body, it's going to start to deliver oxygen. The more depleted the tissues are in the oxygen, the more oxygen the hemoglobin releases. So we can see the line starts to dive down or slope here. But now, look at this red line. The pH is 7.2. 7.2 might indicate that those tissues are much more active. They're producing a lot of carbon dioxide and the pH is falling. So notice that the line gets even steeper and it gets shifted to the right here. And so what's happening is at 7.4, let's say, for example, if a tissue has a pH of 7.4, then the gaseous pressure of the oxygen is only about 40 millimeters of mercury. But look if the pH is a little bit lower, now the gaseous pressure is about 50 millimeters of mercury right here. So what's going to happen? A decrease in pH is going to cause hemoglobin to release more of its oxygen. So the line gets steeper and the blood's going to release more oxygen at that lower pH. Notice up here, if the pH is a little bit higher, say 7.6, then that's not as active a tissue, and so the tissue doesn't require as much oxygen, so the higher pH is going to result in a slower release of oxygen in that tissue. Now, if we were looking at temperature, what would these be? Well, let's say the green line, what's normal body temperature? About 37 degrees Celsius. Well, what if the body temperature were 38 degrees Celsius? Which one of these lines would represent 38, do you think? Did you say this red line right here? Because the higher the temperature, 38 versus 37, the faster the oxygen is going to be released, so the steeper the line. This one would be what? So we got 37. This would be 38. This would be maybe 36 degrees Celsius. Okay, lower body temperature means, or lower temperature means less active tissues. Less active tissues don't require as much oxygen, so the hemoglobin is not going to release oxygen in those tissues as rapidly. All right, that's going to take us to carbon dioxide transport, and I think this is a good stepping off point for our first lecture. We'll end with that, and in lecture number 2 on the respiratory system, we'll pick up with carbon dioxide transport. But let's take a little bit of time to digest what we've learned here in 1 up to this point in time.